Hello everyone, I welcome you all to my presentation on rectum. What is rectum? It is the distal part of large gut, and where it is situated? It is situated between the sigmoid colon and the anal canal. It is located in the lesser pelvis, and as the name suggests, rectum, it is not a straight viscera, but it is curved anteroposteriorly and sideways. It doesn't have the cardinal features of large intestine. Saculations, appendices epiploiky and tinea, they are absent in rectum. Where it is located? Anterior to lower three pieces of sacrum, as we can see in the diagram that it is present anterior to the sacrum, and its extent is from rectosigmoid junction at the level of third sacral vertebra, and it ends at the anorectal junction by becoming continuous with the anal canal. In males, this anorectal junction, it lies opposite to the apex of prostate. Its dimensions are that it is about 12 centimeter long, and the diameter, it varies. In the upper part, diameter is similar to that of the sigmoid colon, that is 4 centimeter, but the lower dilated part is known as rectal ampulla. And clinically, this rectal ampulla, it lies 15 centimeter above the external anal margin. What is the course and its direction? It has certain flexure. As I've already told you, it is not a straight structure, and it has certain flexures. One is sacral flexure and the second is the perineal flexure. So first of all, what about the course? This rectum in the upper 1/3 is directed downwards and backwards. In its middle third, it is directed vertically downwards, whereas in its lower third, it is directed downwards and forwards. So this is the direction, and the curvatures. The anteroposterior curvature is known as sacral flexure, whereas the perineal flexure of rectum, which is the second flexure, is the backward bend at the anorectal junction. And this anorectal junction is maintained by certain fibers of levator ani, which are known as puborectal sling, which is helpful in maintaining the continence of rectum. This is known as rectal continence. Then apart from these antero-posterior curvatures, there are three lateral curvatures also. Upper lateral curvature is convex to right, and it lies at the junction of S3, S4 vertebra. Whereas middle lateral curvature is convex to left, and it is most prominent. It lies at sacrococcygeal junction. Lower lateral curve is convex to right, and it lies at the tip of coccyx. Now we come to the what are the relations. So this diagram represents the curvatures of rectum. Here we can see in diagram A, the anteroposterior curve sacral flexure of rectum follows concavity of sacrum and coccyx, whereas the perineal flexure of rectum is the backward band at the anorectal junction, which is maintained by the puborectal sling, which is the fibers of levator ani. In diagram B, we can appreciate three lateral curvatures. Upper lateral, which is convex to right, then middle lateral, which is convex to left, and the lower lateral curvature, which is convex again to the right, and it lies at the tip of coccyx. So coming to the relations. So after the peritoneal relations, we come to the visceral relations. Anterior relations, first of all, we'll talk about in males. The upper two-third of rectum is, we know that it is covered by peritoneum, that is a peritoneal part, and it is related with rectovesical pouch in males, coils of intestine, and sigmoid colon. Whereas the lower one-third, which is the non-peritoneal part of rectum, is related with base of urinary bladder, ureters, seminal vesicles, prostate, and vas deferens. In case of males, these are the anterior relations. Now, visceral anterior relations in case of females are upper two-third of rectum is related with rectouterine pouch, and lower one-third is related with lower part of vagina in case of females, as you can see in the diagram of female pelvis on right side. So coming to the posterior relations of rectum, which are same in both males and females. We have already talked about that how the rectum, it lies anterior to the sacrum. So they are bony structures, are three pieces of sacrum and coccyx, as you can see in the diagram. Then there is a ligament, anococcygeal ligament. Muscles are piriformis, levator, and icoccygeus. And then there are certain vessels. Median sacral artery, which arises from the dorsal aspect of aorta, then superior rectal, which is the continuation of inferior mesenteric artery, and lower lateral sacral vessels. And on either side we can appreciate green color structure, sympathetic chain, and they are meeting at the near the coccyx, and then we have a ganglionated structure over here, which is ganglion impart, and lymphatics and fats. These are the posterior relations in both male and female of rectum. So coming to the interior of rectum, which is of special mention because it is not a smooth inside, and it shows certain folds, two types of folds, longitudinal folds and the transverse folds. The longitudinal folds, they are temporary, whereas transverse folds, they are permanent. And longitudinal folds, they disappear when the rectum is distended, and the transverse folds, they are permanent and more marked when the rectum is distended. They are four in number. They are semilunar in shape, and the uppermost fold, the first small transverse fold, it projects it is present at the beginning of rectum, and it projects from the right wall. It is situated about 12 to 14 centimeter above the anal canal. Then, and it can encircle the rectum sometimes. The second fold, it lies near the upper end of the rectum, and it projects from the left wall. It lies about 7.5 centimeter above the anus. And then the third transverse fold, which is the largest and most constant of all, and lies at the upper end of the rectal ampulla, and it projects from the right wall. Fourth transverse fold, which is inconstant and lies 2.5 centimeter below the middle fold, and it projects from the left wall. Coming to the vascular supply, for that purpose, basically we divide the rectum into three parts. The upper one-third of the rectum is supplied by superior rectal artery, and upper two-third, basically it is supplied by the superior rectal artery in addition with the middle rectal artery, and distal one-third is supplied by the inferior rectal artery. So superior rectal artery is the chief artery of rectum, as we can see in the diagram, and it is basically the continuation of the inferior mesenteric artery, which is the artery of hindgut. And first of all, it divides into certain branches, right? And opposite the as three vertebrae, it divides into right and left branches first of all, and then each branch then further breaks up at the middle of the rectum into certain small branches also, which basically they pierce the muscular cord, and then they run till the anal columns. You will study in the class of anus that at the junction of the upper two-third and lower one-third of the anal canal, there is a line, there are anal columns, and their curved margins, they are the anal valves basically. So till there, these branches, they are there of superior rectal artery, and here they form the looped anastomosis. Then the second arterial, sorry, this superior rectal artery. It is forming looped anastomosis in the submucosa, and then from this plexus, straight vessels they descend basically in the anal column. And here they anastomose with the branches of inferior rectal artery at the pectinate line, which is formed by the joining of the anal valves. So there is anastomosis, a rich anastomosis between the branches of superior rectal artery and the inferior rectal artery. Then we have middle rectal artery, which is the second source of arterial supply. It is a branch of anterior division of internal iliac artery, and it only supply only the superficial coats of the rectum, and it is supplying the lower part of rectum. Third source is the inferior rectal artery, which is a branch of internal pudendal artery, and it passes across the ischiorectal fossa. And then here it anastomosis with the branches of superior rectal artery. Venous drainage is very important here in case of the blood supply of rectum, because it is a site of portocable anastomosis. Also the veins of rectum, in the middle anal canal, the portocable anastomosis, it is there, and it is the dilatation is there whenever there is portal hypertension, resulting in the formation of piles or hemorrhoids. So again there are three veins: superior rectal vein. The tributaries of superior rectal vein, they begin from a plexus, which is the internal venous plexus, and it is present in the submucosa. And these tributaries, they begin in the form of three veins basically, and then they pass upward and they unite to form superior rectal vein, as we can see in the diagram. In certain books it is written that three veins they are there, and in certain books it is written the three large veins basically they are there, otherwise there are small six veins, otherwise there are six veins in total. And then it drains, then the superior rectal vein continues as the inferior mesenteric vein, which ends in the splenic vein, and it results and it helps in the formation of portal vein. So this is the part of portal circulation. The middle rectal vein drains into the internal iliac vein, the second vein which is responsible for venous drainage from rectum. And then inferior rectal vein arises from the lower part of the plexus and drains into internal pudendal vein. So middle rectal vein, inferior rectal vein, they are basically ultimately draining into the IVC. We can see right. So the mid anal canal is the site of portocable anastomosis, as I've already told you. And the superior rectal vein is a tributary of portal vein. It forms anastomosis with the middle and inferior rectal vein, as we have already seen, which is the tributary of inferior vena cava. So it can result in hemorrhoid. Dilatation of the veins is there, which will certain times it will result in the bleeding per rectum. So here we can see that how the various veins of rectum, they are the site of portocable anastomosis. Here we can see the superior rectal vein draining into inferior mesenteric vein, then splenic vein, and ultimately the portal vein. And middle and the inferior rectal vein, they are draining into the inferior vena cava. So they are the site of portocable anastomosis. Then this is the diagram which depicts the lymphatic drainage. Upper half of rectum drains into the inferior mesenteric nodes, and the lower half drains into the internal iliac group of lymph nodes. Nerve supply is by both sympathetic and the parasympathetic. Sympathetic supply comes from L1 and L2 segments of spinal cord, and parasympathetic supply comes from S2, S3 and S4 segments of spinal cord. Now there is a condition which is known as rectal prolapse, in which there is a protrusion of the rectum through the anus, and this is prevented by certain types of supports of rectum, which are pelvic diaphragm, which is nothing but the levator ani and the coccygeus muscle, then fascia of the wall there, which is a connective tissue behind the rectum, and the lateral ligaments of the rectum, fascia of Denon Villiers, then the we have the reflection of the pelvic fascia also, which is providing support to rectum, and perineal body and fat. These all structures are providing support to rectum. If something happens to these structures, then there will be the protrusion of the rectum from the anal canal, which is known as rectal prolapse. So coming to the applied, we have already talked. There can be the prolapse of rectum, which can be complete or incomplete. In incomplete prolapse, only the mucosa it protrudes through the anal canal whenever there is excessive straining during defecation, and this is because of the imperfect support of the rectal mucosa by the submucosa. In certain cases, we have complete prolapse, which is known as procedentia, and in this condition, the whole thickness of the rectal wall it protrudes through the anus. Then some part of the anus or some part of the rectum it can protrude, that is known as rectocele. Then carcinoma of the rectum is also very important, and it is quite common and situated at the rectosigmoid junction. It can cause bleeding per rectum because of certain ulceration, and this condition is treated surgically. And rectal incontinence can be there whenever there is a damage to the puborectal sling or the anorectal sling, and we have to operate this anorectal ring. We have to tighten it if we want to prevent this rectal incontinence. Then the certain very important examination is the per rectal examination, which is used to assess the condition of various pelvic viscera. We can a finger is put in the rectum through anus, and we can assess the what is the situation. Various certain structures can be palpated. In case of males, by PR examination, we can palpate posterior surface of prostate, seminal vesicle, vas deferens. Whereas in females, we can appreciate perineal body, cervix, and we can also appreciate in both the cases anorectal ring, coccyx, and sacrum. And proctoscopy and sigmoidoscopy are these are the investigations which are done to examine the rectum, interior of rectum, by using certain instruments, proctoscope and sigmoidoscope. So, thank you all for patient listening.